go over the anatomy and some procedures of the anatomy of the abdomen. A little review here. The abdominopelvic cavity extends from the diaphragm to the bony pelvis. It consists of two parts. You've got the abdominal cavity, which is larger and more superior, and then you've got the pelvic cavity. Some of the things that are in this abdominopelvic cavity is the stomach, small intestines, large intestines, liver, gallbladder, spleen, pancreas, and kidneys. But in the pelvic region, you only have the rectum, the sigmoid, urinary bladder, and the reproductive organs.
Will there be questions about anatomy?
Nope, somebody just asked that. Your quiz will only be over chapter 3.
But like for just in general, like for our final or even when we test out at the end of the program, will they ask anatomy questions?
Oh, 100%. Yeah. Yeah, but safely, all of you at least had to get a C or better in anatomy to get into this program, right? If you didn't, I don't know how you got in here. Love anatomy. The peritoneum is the double-walled membranous sac that encloses the cavity. You've got an inner layer and outer layer. The inner layer is called the visceral peritoneum, and the outer layer is the parietal peritoneum. The retroperitoneum, space behind the peritoneum, the things that lie in there are the kidneys and pancreas. Can you tell me what kind of slice this is through the human body? Sagittal.
Yeah, I was thinking.
You gotta start thinking in sagittal slices, right? Sagittal, coronal, right? When you get to cross-sectional class. Alright. Little questions. Which of the following is located in the abdominal cavity? Very good. Which two of the following are in the retroperitoneum? The pelvic cavity contains everything except it is B, gallbladder. That sigmoid colon better be down in your pelvis, or you got issues. It does. It's an error. Yeah, I fixed that this morning, but apparently it did not transfer over. Some preliminary procedure guidelines, right? Breathing's a little different for the abdomen over the chest. Your exposure technique is a little different from the chest, right? You're going through a little denser part of the body, a lot more fat. Proper immobilization. You have to think about your IR and collimation size. SID is a little different on the abdomen. Where to place those markers, whether or not you protect or shield the patient, and then giving clear instructions. So when talking about the exposure techniques, you're needing to see a little more soft tissue, okay, on this. So a high KV, anybody remember what you do a chest x-ray at when you were in lab?
72.
Oh wait, what's the KV? On the computer screen in the control panel, anybody remember? 100 or chest? 120 is general, right? But it should be 100, unless you're doing a little kiddo, right? Because you got to think about part thickness, okay? So high KV is going to over penetrate some of those soft tissue structures in the abdomen, okay? So some things that you need to be able to see on a well penetrated abdomen x-ray. When I saw these things for the first time, I was like, what in the heck is my instructor talking about? So I'm going to point them out. Okay? You've got the liver shadow. Okay? That's what this is on the right side. Thankfully we have a marker. Then it took me a long time to figure out how to see the kidneys. And not everybody's kidneys you can see. If they've got a lot of bowel, a lot of air in their bowel, it's kind of hard. But this is a pretty good demonstration of that. Here's a kidney, and that left kidney, hiding out over here, okay? Then you need to look at your psoas muscles. Now, you're not gonna see psoas muscles on some fluffier patients quite as nicely as you are on someone like this. You can kind of see that muscle right in through there, okay? You obviously want to see some ribs, but you also want to see just enough of the bony detail in the pelvis and then even in the thoracic spine and see those transverse processes coming off the thoracic spine, or sorry, lumbar spine, okay?
Please go say it, I'm sorry to make you walk back over, but
Yeah.
I need to see the first thing again, because.
The liver border or the kidneys?
The kidneys, because I'm
Okay.
like, no, ma'am, I don't see it.
So you can see the right one really well.
Yeah, I see it now. Now
Okay.
that you're circling it
Yeah.
really well, I can see it.
The left one is a little harder because there's a little bit more going on here.
Uh-huh.
I got some poo in there. Okay? So this is where anatomy really comes in handy because you need to know which kidney sits higher.
The right.
No? Why would the right not sit higher?
The
Because the
gallbladder.
liver. Right? So the left is going to sit a little higher. Okay? It does. They actually look pretty equidistant on that, but again, there's something going on in that left.
That's why I said the right, because it looks hungry.
Right. But know your anatomy. Right?
So you can see like the kidney, bean shaped kidney, like
Yeah.
on
We
that
used to do
liver.
IVPs and you could really see them then.
So the kidneys will, you said there'll be the liver shadow and then the kidneys, like, you can especially see it.
On that picture you could, yes.
Okay.
If they have contrast from like a CAT scan or something, it might even be highlighted even better. Like say they go to CAT scan and then you bring them over to do something KV, which seems redundant because they just had an abdomen CT, but doctors do that.
So, what is the average KVP for abdominal since it's
Oh, yeah.
from chest?
We're getting to that. Okay. But don't do 100 unless the patient is really big and you're trying to penetrate a lot of soft tissue. The prime requisite in abdomen x-rays is to prevent voluntary and involuntary movement, right? We all know what voluntary is. Patient's fidgeting, rolling around. Steps to prevent this, again, making the patient comfortable. Everybody's laid on that table at least once yet, maybe? No? Oh, don't shake your head, girl, because now you're gonna lay on the table. You're gonna be somebody's spatial force supine. So, I say table because it is a table. Hold on. It is a table. It is not a bed, right? So, making them comfortable is very important. Explaining the breathing to them is also very important. Same thing applies with our chest x-ray, right? Explaining, I'm going to give you 2 sets of breathing. I need you to take a breath in, blow it out, take another big deep breath in, and hold it. Okay? You want to give them a second to follow your breathing instructions and make sure they blow all their air out. When you get a little fluffier patient too, sometimes you get belly movement, right? You get a guy come in, big beer belly, and you'd be surprised when he blows all of his air out, how much some of that soft tissue is still moving. Okay, so wait a second or 2 before you expose. Voluntary motion tends to blur the structure a little bit. That last image was not, that was only like peristalsis and stuff. That was no voluntary movement in that picture. And you can kind of see where it blurs in the bowel gas patterns on your x-rays. Peristalsis is an example of involuntary, right? Can't get that to stop. You don't want that to stop for your patient. You're going to be very constipated. Involuntary contractions of the abdominal wall or muscles around the spine can cause movement of the entire abdominal area. So, if the patient is maybe having back spasms, right, catching them in between a hiccup and timing it is imperative, right? KVP range that is too high will over-penetrate some structures. We're gonna not repeat what I said before, but those are structures you need to be able to see for a well-penetrated x-ray. You're gonna use the smallest IR that you can, not keep it open all the way, so 14 by 17 is acceptable. You're gonna try and collimate that down, right? For smaller, thinner patients, you're gonna collimate to within 1 inch of the shadow on the sides of the abdominal flank, right? So, myself personally, they may not be able to collimate too much, right? SID used to be 48, unless it's otherwise specified. Merrill's goes by 40. Okay, 40 is acceptable. Your markers, make sure you're appropriately using a left or a right marker. Avoid using a digital. I don't think I have to keep saying that to you guys, you get it. If for some reason you're doing like a small valve follow through and you might have to have like a minute marker or something on there, you can add that. Close collimation helps what with the patient exposure?
Patient dose.
Decreases the patient dose. It also helps with optimal technique factors. You can shield the gonads as long as it's not in the primary beam, and always follow your state regulations, and if it helps to keep the patient from being a little anxious, okay? You should always explain and demonstrate what you're asking them to do. Exposures of the abdomen procedure generally made at the end of an expiration to avoid compression of organs. So it's on expiration, not inspiration. Some essential projections we're going to go over. You've got the AP, supine and upright views. Then you have a PA, upright. AP, left lateral decubitus position. A lateral right or left. A lateral right or left dorsal decube position. So, you'll get this ordered a lot, either a 2-view or a 3-view. A 3-view can also be called an acute abdominal series. It includes a PA chest or an AP chest. That's acceptable to flip-flop them. But you need to get an upright abdomen and you need to get a supine abdomen. This demonstrates free air and air fluid levels. So a lot of times they're going to ask you for a acute abdominal series for a patient that's maybe having bowel pain or upper quadrant abdominal pain after surgery. And they might be looking for free air, right? Because free air will kind of float and stand right up underneath that diaphragm in the upright abdomen. Another common request is a 2-way, which again is just an AP supine and AP upright. Don't really care about the chest for this one. For both procedures, a left lateral decube is performed in lieu of an upright if the patient can't stand. Okay? So I won't go much farther than this, but at least you guys can get a feel for what an AP abdomen supine is. It's also referred to a KUB, right? A lot of texts don't run around just saying AP supine abdomen. We'll say KUB. So that means that you're going to demonstrate kidneys, ureter, and bladder in your projection. The patient position is supine. The part is positioned so support the knees to reduce the strain on the back. This really does help. If a patient automatically starts bringing their feet up to bend their knees, let them. It helps to take stress off the low back. Ensure the pubic synthesis is included. For tall patients, obtain a second image for bladder. So sometimes long torsoed patients, you're going to have to do 2 pictures anyway. The IR is centered at the iliac crest. The CR SR is perpendicular to the IR. And the patient, and it enters the patient, sorry, at the MSP at the level of the iliac crest. Can everybody find their iliac crest right now? Alright. Hands on your hips.
So you need to do a Shakira dance, is what you're saying?
A what? A Shakira dance?
Yeah.
Yeah. Yes, I wanna see that.
Yeah, that's good.
So this is what it looks like with a patient. See how they've got their knees elevated just a little?
Can we use those like triangles,
Mhm.
sponges too?
When you're in the hospital, you can use whatever they have. Some people double up pillows. You can use a triangle sponge. CT has a really great sponge. It's huge. It's long. Collimation. You should only be radiating the 14 by 17 field size. For smaller patients, again, you still need to collimate down. You should only have about 1 inch of shadow on the sides of the abdomen. Think about the body habitus. Hypersthenic patients may require 2 crosswise projections, right? We do quadrants on some patients, unfortunately. You might get a patient that's rather large and they have herniated their bowel cavity, and so some of that bowel gas and pattern actually spills out into the soft tissue that's out on the side. So that will require you, yep, you're making the face, but it is true.
So what do you need? I'm sorry, Miss Roseanne.
So-
Scott,
You're gonna take 4 pictures,
that's what I was gonna ask.
okay?
Okay. Thank you, ma'am.
Tall patients may require a separate bladder image. So you may have an actual, you felt for the crest, you're lined up at the crest, you've got the top, so you've got the top of the kidneys, right? You've got the kidneys on the first one, but because they're just a little longer, you're not quite getting all the pubic synthesis in the bladder, so you may have to take what's called a bladder spot, okay?
Will we be showing how to do that?
Who's my tallest person in here?
Oh,
Cheyenne's pretty tall. How tall are you? Okay. And again, exposure needs to be at the end of expiration. Right. Again, you need to see these things, right? If you've penetrated the abdomen properly, you need to see the size and shape of the liver up there in the ribs. You need to see the spleen. The spleen's kind of hard to see. The kidneys, most people's kidneys you can see. And intra-abdominal calcification or evidence of tumor masses. These are great for kidney stones. If the kidney stone is large enough to see on an x-ray, you know that patient is not feeling well. Some evaluation criteria is you need to see evidence of proper collimation. Okay? A lot of techs get lazy and they just don't collimate. Area from the pubic symphysis up to the abdomen, 2 images again may be required. Proper patient alignment to ensure the following: that you're centered to the vertebral column. You see ribs, pelvis, hips equidistant to the edge of the image and collimated borders. No rotation, right? I've had plenty of morbidly obese patients where unfortunately they have so much extra soft tissue coming off of them that one side might be a little larger than the other and it pulls them one direction and it actually rotates their body internally. So you may have to prop them up with sponges, right, to get them to look straight. You need the spinous processes in the center of the lumbar vertebrae. You need the ischial spines of the pelvis symmetric. And the wings of the iliac symmetric, right? These are your wings, by the way, guys. Okay. Soft tissue brightness and contrast showing the following. You need to see the lateral abdominal wall or the flank strip. Sounds like I'm eating steak. Those psoas muscles, the lower border of the liver and kidneys again. You need to see some of the inferior ribs. And again, those transverse process on the lumbar spine. And don't forget your marker they were also referred to flank pain for kidney pain, right? So along the sides. So we're talking about the flank, okay?
So since we're talking about poop, just,
Oh, I love talking about food.
yeah.
Go ahead.
Well, that's what I was just asking. We were talking about the poop earlier. As the program progresses, are we going to learn how to deal with the poop?
Oh, you mean like a poopy patient?
Yeah. As
Yeah.
far as like with the x-rays and having to take the x-rays and all the poop spilling out, like, you know what I mean?
I mean, I don't feel like I learned that in class. I learned that on the job training.
Well, yeah, I know it'll be on the job training, but
I'm just gonna encourage y'all not to run away from the poop.
Oh, I'm not scared of poop. Right, and shoes. Oh, no.
No, so if you have got this patient on the table, right, you've got them all lined up, you are ready to shoot that KUB and they shat themselves
You gotta clean it up.
after you take the x-ray.
Yeah.
Why would you just go ahead and go, oh, okay. And the patient most of the time, unless they don't have some of their faculties, will go, and then you just say, it's okay. This happens. We're gonna get your x-ray real quick and we'll get you out of it, okay? Ensure the patient that you're gonna take care of them, right? That's gonna help them. They're gonna feel embarrassed, right? So make sure that you help them and help them the best you can. If you're like, if it grosses you out, right? You don't know until you get into some of these situations, guys. Sorry, hold on a second. You don't know. If it grosses you out, go get help, okay? Find somebody that will help you. Know your limitations. I don't do sputum. That's why I didn't go into respiratory care. I don't do sputum. I have a real hard time if I'm in a room and I'm doing a portable chest x-ray and respiratory comes in, they just go and they're making that sound and it just goes and I'm about ready to barf. But I have to kind of put myself someplace else. I have to focus on my job, right? And think about the person that's in front of me because that is a living, breathing person. I have to get over myself a little bit. Sounds harsh, we kind of do, okay? So to learn how to deal with the poop, I got tips and tricks for you, but you're not gonna learn that in here.
Yeah, no, I just wanted to know if there's gonna be extra people that help you, because I'm
Oh, go get people, and if somebody's not helping you, girl, then let us know.
Yeah, CNA, you're.
Oh, well, CNA's,
You know what I'm
no.
saying? We got those.
It is a great field, but CNA's always get the
always
wind
get
of the
the
stick,
wind,
literally.
yeah.
Yes, I understand that. Yeah, I get it. Lisa?
I was just gonna say, when you were talking in reference of like poop spillage, you were talking about like outside the bowel but inside the body, right?
Well, her question was, like, if you get a patient that has an accident.
And they just.
I was asking
Well,
about
because
this.
you had said spillage, so I thought you were referring to when she was talking about.
Can you
that.
guys see the poop on this image? Okay. Who can't see the poop? Thank you, Emily, for being honest. Okay. So, here's the air bubble. We see that air bubble? Okay. So, when you take a scout image when you're doing fluoro procedures, a lot of barium procedures are of the abdomen, okay? You're gonna take a scout image. This is a perfect scout image. There's air, right? This is down on their pelvic. So, if I had to guess, what part of the bowel could this be?
The rectum?
The rectum or the
Sigmoid.
sigmoid? Very good. Okay. This is probably part of the ascending, right? Then you have the transverse that goes across, and then the descending, okay? So your appendix is over here, but there's an air bubble, and then there's stuff that looks like it's in there, right? Kind of looks flaky. I'm trying to describe it better. But you can see air down here, and there's like flaky stuff. And then there's more flaky stuff over here if you follow the bowel pattern, okay? When somebody's truly, truly constipated, like you'll definitely see it down in the pelvic area because it's stuck in the rectum and the sigmoid, okay? But thank you for your honesty and anybody else that was like, oh, I'm just gonna raise my hand. But you'll pick up on these things, guys, right, over time, okay? Class is over. Sorry if I went over a little bit, but we got started at least on the abdomen, which we